Today I want to go over an introductory chapter to the care of pediatric patients. There's a lot of differences between the care of pediatric versus adult patients, and today I want to go over just some brief things and kind of get our minds jogged to see what we need to be thinking about differently for pediatric patients. And then in the next mini chapters, we're going to go over the intricacies of how to actually take care of these patients. These are just a few things to remember today. Pediatrics is divided into a lot of different age groups and sections. Not as concerned about the older ones, school-age children and adolescents. I think a lot of the confusion with these patients happens early on with the neonate, infant, and toddler age groups. The age groups do play a role in kind of resuscitation and things like that. So it's important to remember neonates birth to 1 month old, infants are from 1 month to 1 year old, and then toddlers are from 1 year to 3 years old. Some general information to be kind of aware of: screening labs in pediatric patients really lack sensitivity. Don't stick these kids just thinking, I'm just going to get a bunch of labs and see what shows up. It's not really going to be helpful for these kids. Labs do not necessarily correlate with a lot of different things in pediatric patients. We need to be careful on the CT scans that we're ordering. There's a 1 in 2,000 chance of fatal malignancy developing from an infant CT scan. That gets better with older children, but still not negligible. 1 in 5,000 chance for older children. So we know we need to be careful about these, but it's always something to keep in mind. Fast exams are not going to be as reliable on pediatric patients. Before we take care of any of these patients, we need to be sure that we have consent to treat them. A kid showing up in the emergency department because his ankle hurts without a parent or anyone else there, not really going to be someone we can treat unless we have consent to treat. This gets a little different if this is a reproductive concern. If this is a patient who shows up, says, my parents don't know I'm pregnant, I'm bleeding, or the kid who says, I want to kill myself. These are things that we need to treat. There, we can treat them without consent. Anything to do with mental reproductive health, okay to treat. But anything else, be sure you're getting permission from parents. Vital signs in these kids are different. Obviously, they're going to have very different vital signs from adults. And we need to remember that they actually compensate differently than adults as well when analyzing and evaluating, interpreting these vital signs. Remember that a rectal temperature through about the toddler age is going to be the most effective and accurate. A temporal or axillary oral temperatures not going to be helpful in these kids, especially in these infants and neonates. Make sure you have a rectal temperature. That's going to be what's going to be accurate. There are multiple ways you can remember to estimate the weight of these different infants and kids based on their neonatal period or infant period. Not really concerned about that. If you really need to know that and you don't know that information, get your Broslow tape out and use that. Same goes for systolic blood pressure. Make sure you have a Broslow tape handy or some tape. Well, it's just not worth having the mental strain in having to remember, the formula in a real emergent situation. Before we kind of start talking about some of the systems that we need to be aware of and there's some differences that occur in these systems, we need to remember that the history and physical exam is going to be a little different in kids. Often these kids are not going to be too helpful, and a lot of the history is going to be taken while talking to parents or guardians or somebody else in the room when the kids can't really talk for themselves. Make sure you're asking the parents' birth history. Ask about any maternal issues, any complications with pregnancy. any family history, any sort of inherited diseases that are in the family. That can really kind of guide your thoughts in assessing and evaluating that patient. Now, I just want to kind of go through a couple systems before we end here and talk about just some differences to keep in mind. With respiratory system in these kids, remember that kids typically are going to compensate by increasing their rate. So they're going to have tachypnea rather than hyperpnea. They're not going to really be able to effectively or efficaciously increase their depth of breathing, which is hyperpnea. It's going to be by increasing that rate. With cardiac, we really focus, especially in these really young kids. If there's cardiac arrest in these patients, it's usually not a primary cardiac cause. It is most often a respiratory cause, and that's why neonatal and infant resuscitation is so heavy on respiratory support and positive pressure ventilation. It's something we're going to talk about much more later, but they are mainly focused on or mainly secondary to respiratory arrest. So always remember that. With cardiac output in these kids, remember stroke volume and heart rate make up our cardiac output. Kids are going to increase their rate. They're going to become tachycardic rather than increasing their stroke volume. Musculoskeletal system, something to be aware of here. Sprains are going to be sprains and strains. Remember that ligaments in these kids are a lot stronger than bones. And so if we're concerned about a sprain versus a fracture, there's a high chance that it could be a fracture because the bones just aren't as strong. With GU, always remember with GU in these neonates and infants, they don't hold on to urine like we do. They are not going to hold on to it long enough for anything to grow in their bladder. So the UA is really not as sensitive in these young infants because they just don't hold on to the urine long enough for anything to really start growing. In the neurologic system, it's an interesting fact that in patients with bacterial meningitis, especially the infant patients, meningismus is only going to be present in less than 15% of these patients. So that's a really small percentage. So don't hang your hat on meningismus being part of your evaluation for meningitis or other things. If it's not there, they still very well may have bacterial meningitis. Also, to keep in mind is any psychiatric concern. You want to assess, especially in these older kids, risk-taking behaviors. I wouldn't start asking younger kids a lot of these questions, but these older kids need direct questions about their risk-taking behaviors. That is something really important and really something that you can provide a lot of guidance towards early on. That's gonna save them from a lot of issues later on. This is the end of our introduction chapter. There will be much more to follow as we really delve into how to take care of these pediatric patients. Thanks.